I would like to know a little bit which are the hints or which are the main important factors for long-term evaluation in implant therapy that you're going to talk about today.
Yes, there are several aspects to be mentioned here. You see, I think to have long-term success with dental treatments, you need first to have well-established protocols. I would call them evidence-based concepts. Second, you should only use biomaterials with a good track record in good documentation. And thirdly, you should be a good clinician to do the treatment.
So, Dr. Brewster, how do you think it influences the long-term stability of the implant therapy based on hard tissues and soft tissues?
What I learned in the last 32 years of my experience is that the circumferential surrounding of the implant by bone is the number one prerequisite for long-term stability. That means when you put an implant in, you should have on the buccal and on the lingual wall side at least 1 millimeter of bone. If that is not there, you either have to reduce the diameter of the implant or rebuild the bone with a GBR procedure.
And do you think that the position of the implant, not only considering the buccal plate thicker than 1 millimeter, but do you think the apical coronal position of the implant might influence the long-term result of the implant stability?
That I don't know. I don't think so. You see, when you are putting implants in a posterior area, then the position of the implant in a vertical direction is not such of importance, because we know that the ratio between crown length and implant length does not influence the long-term stability of an implant. It's a different story in the aesthetic zone. There we are limited to go too deep into the tissues, because this is causing then aesthetic problems.
And going back to the tissues surrounding implants, we already know that 1 millimeter of bone is enough to preserve stability in long-term basis. But do you think there's a limit on soft tissue thickness in order to be safe, especially in the aesthetic area?
We always have been very, very decided to go for implant sites that the implant should be surrounded by keratinized mucosa. So we have always done everything to maintain or re-establish keratinized mucosa. This has been a debate, ongoing debate for many years, in particular in the perio groups. But now I'm very pleased to see that the most recent systematic reviews clearly show that there is a need for keratinized mucosa, because it helps to reduce the plaque accumulation, it reduces the inflammation of the tissue, recession of the gums, and so on. And I'm going to show this study actually in my lecture.
Good, because lately there is a lot of presentations from several clinicians that are talking. At the beginning we used to think that at least the width of the keratinized tissue was important, but today a lot of people believe that it's not the width but the thickness of that tissue that it's important. Do you think there is a ratio of relationship, or it doesn't matter the amount or the thickness as long as you have some?
We know in the aesthetic zone that when you have a thin biotype or phenotype, that these implants are more prone to develop a recession. So I think for the stability of the peri-implant soft tissues, the thickness also plays a role, yes.
And Dr. Brewster, not talking about tissues now, but about implants, how do you think that the design of the implants play a role in long-term stability?
I think the implant surface certainly plays a role. Going back 30 years, we have had only two surfaces: the machine surface, very smooth, or the plasma sprayed coated surface is very rough. And today we have on the market these so-called micro rough surfaces. So they are in the middle of the range of roughness. And these roughness values are very good for bone integration. But it should not be exposed to the oral cavity, because they also facilitate the plaque accumulation or the biofilm accumulation. So when I place implants, and I will address that, I always put this border between smooth and micro rough surface clearly below the crest to go more into the safe zone with these micro rough surfaces.
And now, just to finish this interview, besides all the topics we just talked, there is any recommendation or something that we haven't mentioned that you think it's important to consider for long-term stability of the implants?
If you want to be a successful clinician, in particular for the young generation now, you see, I strongly recommend that they go for excellent educational programs to really learn how to do these kind of treatments, because that is for sure facilitating much better success. And I think that's the challenge in these days, because we have excellent procedures, excellent biomaterials, but we see a certain percentage of colleagues who are not doing a good job, and they are causing a lot of troubles. And that's a certain risk also for the whole field of implant dentistry.
Okay, and sorry, because this is a bit of an informal interview, but I forgot to ask you something that someone in the audience asked is, what is your opinion in the long-term considerations of short implants? Short
implants, we have been using short implants, actually 6mm implants already 30 years ago. It's clear that we are using those implants whenever it's needed. I don't use them when there is no anatomic need. And when we go for these extra short implants, 6mm, even 4mm now, then we always splint the restorations to improve the stability of the restoration. And with this, let's say, with this approach, we have been very successful.
Okay, then I don't want to steal more of your time. I want you to enjoy the Congress.
Yes.
So thank you very much for your time.
My pleasure, thank you.
Thank you.